Anyway, so my name is Omar. I'm IMT1 in Charlie Hospital. Today I'm going to speak to you about heart failure. I'm not going deep in it like a proper cardiologist. I'm just going to give what you need as an SHO or a non-specialist just to be aware of. So if you're not a specialist, if you're having a patient with acute heart failure, if you have a patient even on chronic heart failure, just to be aware of what's going on. This is basically the main purpose of the session, and I'm going to give some explanation of the rest of it. Okay, so first of all, if you say, okay, so first question is, what's heart failure? And then to answer this question, you simply need, I'm going to ask you, what is the function of the heart? So in this case, if I ask any medical student, or even high school students, you will just answer the heart is a pump. So actually this is right. So the heart's main function is pumping blood from the venous system through the lungs and back to the arterial system again to the body. Just a quick idea that the average size of the left ventricle is can accumulate up to 70 mL of blood, and usually, just a rough again, the heart rate is 70 beats per minute, so this gives you like 4,900 mils, like around 5 liters per minute. Okay, so first of all, how do you know that your heart is failing? Or how do you know that you've got a patient with heart failure? It's simple things. So patient coming with some signs. So sorry, coming with some symptoms. Patient might have some signs and you can find it on some investigations. And we're going to go through them all in details now. Okay, so symptoms of heart failure. Simply, most of the patients do come to the hospital complaining of short of breath, reduced exercise tolerance. They might report some swelling in the legs or feet. They might report some dyspnea. This is, some chest pain, but this is usually non-specific things. This is the most common symptoms of it. And usually, even if the patient comes with one of the symptoms, ideally you should ask for the rest of the symptoms. Okay, one of the most specific symptoms would be paroxysmal nocturnal dyspnea and orthopnea. So patient wake up at the night trying to catch your breath, and patient can't lie flat. You really ask them how many pillows do you need to sleep at night. Even some of them just sleep in sitting position. Signs, again, very classic signs. So you'll find dependent edema. Okay, and in this thing, I want to clarify that if the patient is mobile or the patient can sitting usually in chairs or mobile at home, then you look for the edema in the legs, in the lower limbs. It can be up to the knees, up to thigh, and up to the abdomen. But you just need to know that the patient, like a patient coming from nursing home or long lie, you don't really expect him to be in the lower limbs, so you may need to look for sacral edema as well. Raised GVBs is one of the specific signs, not very specific, but one of the signs as well for heart failure. This is the right side, and you will find sometimes we don't do it in clinical practice, but it's one of the signs that enlarged liver, just hepatomegaly because of congestion. One of the other signs would be one of the most important things that you need to do is to auscultate the lungs properly to find for basal crackles or maybe up to mid lobes, and you will find that on the chest X-ray as well. There are more signs, but this is the most common ones that we usually look for on the acute take. Then investigations wise, you may need to do a few investigations. One of the things is you first start with basic non-invasive investigations. like a regular blood test, ECG, chest X-ray, and the proBNP. Okay, so then we're going to talk in more details about investigations. I'll leave this to the next slide. Okay, so just now, one of the most important investigations for heart failure is the echo. So whenever someone says you got heart failure, then you need to get an echo for it. So what is the echo and how does it work? And what do you actually need to do the echo here? So basically, just this is a very brief diagram of someone's heart. So what you do with the echo is you have a look on the heart, but you just need to know that the echo does give you only 2D 2D view. Okay, so it will show you the heart, like if you got a cut section of the heart, like if you got a proper heart in your hand and you cut with a knife, you will have a look on the heart. Okay, so the first picture here, let's say this is a heart and this is the left ventricle, this is the right ventricle, right atrium, left atrium. On the echo picture, you will find that usually the left ventricle is surrounded by thicker muscles than the right ventricle. Anyway, so what we do in the echo here, we just measure the distance of the left ventricle in the diastole, and then we measure it again in the systole. And basically just the echo machine does the calculation for you, so you don't need to do anything, and then you get a number, which is the ejection fraction. So just a quick idea, what's the ejection fraction? It's how much did the heart contract or the left ventricle got swollen, smaller on each beat. Okay, so just quick idea, there are a lot of causes of heart failure, but just the most common ones are ischemic, if someone got ischemic heart disease, infiltrative like amyloidosis, or hypertrophy as complication of chronic hypertension, or abnormal rhythm. Abnormal rhythm can cause heart failure, especially in AF, and we do see them a lot. So a patient can come with symptoms of heart failure, they got signs of heart failure, swelling, edema everywhere, and then you find them in fast AF. And I've got a patient like this. I need to mention, I think it may benefit my colleagues, that this patient was diagnosed with heart failure, and he was started on all the medications of heart failure, and we're going to speak about it later. And this patient, he was actually diagnosed with heart failure on an echo of AF with 130 beats per minute. In this case, it's not fair to judge someone with the stigmata of heart failure, severe heart failure, on an echo like this. So what happened? The patient was started on the full medication for heart failure, including some medications that can cause acute kidney injuries and can cause a lot of complications for them. So the patient was sent home. He was planned for an outpatient DC cardioversion. And then what happened? The patient was discharged on a lot of medications. He self-reverted to sinus rhythm anyway, and his rate was properly controlled right then, but he was still on the medication because no one knew. Then he came back to the hospital with symptoms of digoxin toxicity and AKI and potassium of 6.8, hyperkalemia. So all of this was started just because the patient was improperly started on the correct medications, the incorrect medication for severe heart failure, while you could have treated him properly, reverted him to sinus rhythm. And because we repeated the echo after the patient came in sinus rhythm and his heart was fine, no reduced ejection fraction. We're going to come back to this later, but I just wanted to tell you this story about one of the patients. So patients can come with acute heart failure, like the guy who came. So if someone comes with acute heart failure, you just need to know what you're looking for and what are the symptoms maybe will come. So congestive heart failure there are a lot of classifications for heart failure actually. So you can classify the heart failure according to the symptoms. It's NIHA classification. You can classify it according to the site, right-sided, left-sided, or congestive heart failure, which means both of them. This is the one I'm going to talk about now. So if you got a patient coming with acute congestive heart failure, a patient will come with short of breath. You can get some wheezy, you get cough. In the legs, you will have lower limb swellings. In the kidneys, they can get congestive nephropathy, so reduce GFR, because basically just the venous blood is not drained or it's congested. So, and the congestion is all over the body, so it comes to the GIT. So it's something called congestive gastropathy. It's one of the complications. So patient will feel sick, dyspepsia, and may to some points vomit. That's why in these conditions, it's prefer to use the IV the IV diuretics, and it can be used for other reasons anyway, because you need higher doses. So in these cases, you just need to offload the patient first. Then we try to manage him on the long term and the short term. So for the short-term management, you need to offload the patient, as I said. This is done by IV diuretics. You need to monitor the patient's kidney functions, because diuretics are really offending medications to his kidneys. It can cause acute kidney injury. You need to monitor the patient's daily urine output to make sure that the patient is in negative balance. So you need to put the patient on fluid restriction as well. And we need daily weights of the patient to make sure that the patient is losing weight, is losing water. Ideally, in this situation, if the patient on medications like ACE inhibitors or ARPs, angiotensin receptor blockers, you need to hold those medications for a while just to give the kidney some time to respond to the furamide and keep your blood pressure as well, because you need to keep your blood pressure up. If you give him diuretics and he's already an antihypertensive, his blood pressure may crash and you will need to hold your diuretics. Anyway, okay. There's a situation that happens in the clinical practice in our hospital, that especially for non-specialists. So on medical wards, yeah, you get a patient with acute congestive heart failure. You start them with furosemide, then you repeat the UNEs, and next day, and you will find the UNEs, the kidney function, are getting higher. The medical consultants, because they are not specialists, they just, okay, so stop the diuretics now. So the patient didn't receive the complete treatment. The patient is not his symptoms not resolved yet, but just because they are scared of the raised kidney functions. To be honest, I always had this fear as well, but I discussed with our senior cardiology consultants, and I was advised that you still give the diuretics as far as the patient is giving good urine output. The patient still symptoms, the patient is still responding and losing weight. You don't worry much about the kidney functions. You do expect them to rise, so it's not a surprise for you. And you know also that this is a temporary thing, and it will return back to his baseline once you treated the patient. And actually, it can return back to better because you relieve the congestive nephropathy. Yeah, so basically for acute heart failure, just go on with IV diuretics. Now, chronic heart failure. So you managed to treat the patient, you treated the reversible causes, and this patient, like let's say, he's got a previous history of an MI. So we did an echo, and the patient, he's got ejection fraction of this number. How do you interpret the heart failure? How do you classify it? And what investigations do you need to do? So we start with the basic investigations first, and then we move to the echo, then the specialist investigations. So, and the patient in the ED or in the acute take, they will start with very simple things: ECG, 12-lead ECG. They will start them with proBNP. proBNP, just for who don't know, it's a marker of ventricular restraint. So if the ventricles are straining, you will find the protein be raised, and this is an evidence of heart failure. However, it is not specific. It can be raised in other conditions like kidney diseases and COPD. So don't jump just to conclusions of severe heart failure. So if it's raised, then this will justify getting a transthoracic echo for this patient. According to the latest ESC guidelines, it was classified, the heart failure was classified into 3 categories. So heart failure with preserved ejection fraction. That means that when you do an echo for the patient, you will find the left ventricular ejection fraction is more than 50%. Then heart failure with mildly reduced ejection fraction, it's between 40 to 49%, and heart failure with reduced ejection fraction, it's less than 40%. In all of them, the patient must have symptoms and signs of heart failure. Then if someone asks like, oh, okay, if the patient's the cardiac function, the pumping function is normal, which is more than 50%, how do you know then, like, what is the heart failure? So we say here that the patient got symptoms of heart failure, but it's not only the pumping action is not working. Maybe it's the receiving part of the pumping action is one is not working. So patient may have diastolic dysfunction. What is diastolic dysfunction? Simply, the heart does contract or squeeze to push the blood, right? So, but if the heart does not dilate enough to accommodate the 70 mils we talked about earlier, that means that it wouldn't have anything to pump. So yeah, the pumping function is fine, but it's not receiving anything. This can be because the cardiac muscle are getting the LV, as we showed here. It can get thicker, and when it gets thicker, it will leave smaller space for filling. And maybe it's thick to the point that it's not compliant anymore, so it cannot receive a lot of blood. Usually the cardiac muscle can get bigger. So if we see here on the big picture, it can accommodate 70, but if it's thick or if it's stiff, it wouldn't accommodate a lot of blood. That's regarding the heart failure with specific ejection fraction. So we start with the basic investigations, then we go when usually the patient will need to be referred by the specialist for further assessment and management. And in this case, the evidence have shown that the MDT and managing the patient by specialist on cardiac ward and being followed up by heart failure specialist nurses does improve the prognosis and does improve the long-term mortality, and it does reduce the hospital admissions for causes of heart failure. So it's really important, even if you're managing the patient well, if the patient is on correct medication, it's very, very important to refer the patient to the community heart failure team to follow the patient. They do very good job. They do monitor the patient's symptoms. They advise them regarding the diuretic doses, increase or decrease, regarding his blood pressure and saturation and all of this stuff. And this does decrease the workload on the cardiologists in the hospital. So let's talk about every one of them, and that will be the last part of my presentation. So if you go to a patient, you got symptoms of heart failure, symptoms, signs of heart failure, you got on the echo, ejection fraction is normal, and you got in the echo as well, there's some diastolic dysfunction. According to the latest guidelines, first of all, treat the reversible causes, that will be in all of them. Okay, so if the patient in AF, if the patient has got chronic hypertension that was complicated by LVH, then we need to treat the hypertension. Then, according to the latest guidelines last year, there's a new medication that's coming that is been in the market for a while. It's called SGLT inhibitor. It's a group of medications. The most common of them are empagliflozin and dapagliflozin. It was evidence proved that they do reduce all-cause mortality and all-cause and hospital admissions with heart failure. Diuretics here, maybe not of you will know that, but diuretics have no prognostic region. no prognostic value, but it is important for symptom management and for recurrent hospital admissions reduction. But on the long term, putting a diuretic or not does not increase or decrease the mortality rates, but it's very important for symptom management. Then we go to heart failure with mildly reduced ejection fraction. The guidelines around this is not very specific, not clear, but again, SGLT2 is indicated, reversible causes, 3 reversible causes, and diuretics for symptom management. Then ABCD, you need it if appropriate. And what's ABCD? We're gonna talk about it in the next slide. So we're talking now about heart failure with reduced ejection fraction. Again, what's heart failure with reduced ejection fraction? When you do the echo, the ejection fraction is less than 40%. Okay, just it was done as ABCDE. Is how my consultants usually used to teach it me, just to make sure that you never forget it. So A would be ACE inhibitor, B beta blocker, C, like, please accept it for me, C is spironolactone, D is dapagliflozin, empagliflozin. It's not like very specific like this. So ACE, A could be ACE inhibitor, could be angiotensin receptor blockers, can be valsartan, sacubitril. B, a beta blocker, it's only the beta blocker. C, spironolactone or eplerenone. Eplerenone is well tolerated because it got less side effects, but it's has a very specific thing, but you don't start it in acute settings. Anyway, D, dapagliflozin. Just wanted, yeah, that would be the symptoms for heart failure, chronic heart failure. You should charge a patient, make sure that the patient is followed up in the community heart failure nurse. D, then the community heart failure nurse, after starting all these medications, you need to repeat the patient's UNEs in 1 week time to make sure that he's not in acute kidney injury or not developing acute hyperkalemia. Will be reviewed by heart failure nurse, and if he's still symptomatic, they can start him on some diuretics for symptomatic management and reducing of hospital admissions. Now there was few things that 3 points I just wanted to discuss. One of them, digoxin. We were told in medical school that in our old medical school that digoxin does help in heart failure. Actually, yes, it does, but it's not indicated in management of heart failure anymore. Ideally, the most common treatment, the most common use now for digoxin is for control of AF. And actually, control of AF when you put in the patient on beta blocker and you still can't get proper control, you try amiodarone, you try a lot of things, and digoxin can help you, but not on mobile patients, like not an actively mobile patient. It won't help there. So basically, digoxin, you don't need it in severe heart failure. Ivabradine, it can be used in patients with reduced ejection fraction, but you need the patient should be in sinus rhythm and ideally sinus tachycardia. It helps you to get proper control of the heart rate. The other thing is CRTD. Yeah, sometimes hear about CRTD devices and people getting device for heart failure. So as a simple thing, just patient, when you do an ECG for the patient, if you got the patient with severe heart failure and white complex, QRS complex is more than 130 milliseconds, then there would be an indication for CRTD or CRTP. The reason behind that is, in this case, the patient is in severe heart failure. He lost the conduction system to the ventricles up to the point that he's either left bundle branch block or right bundle branch block. The conduction system is distorted, and this put him on a great risk of fatal ventricular arrhythmias. This is one of the things. And the other thing is there's evidence that because the ventricles are not contracting with each other anymore, like one unit, as it should be. It's like one of them started, then the electric impulses goes through the muscle, not through the conduction fibers. So it takes longer time. That makes the wider complex. So in this case, one of the ventricles and they're not synchronizing in contraction. So the evidence shows that when you get the ventricles to contract together like normal, this can improve the cardiac muscle. Basically, a CRTD, just for who don't know, it's like a pacemaker with 3 leads. One of them will send the impulse from the atrium for the 2 ventricles and will make sure that the 2 ventricles work together. D is because it's added with a defibrillator function. So in these patients, all patients with severe heart failure are at risk of fatal ventricular arrhythmias. So in this case, you will add a defibrillator function just in case if the patient go in severe ventricular arrhythmia, it will do the shock and will save the patient life. I think this is the end of my presentation, and thank you very much. Anyone who's got any questions, please ask one of the cardiologists.
Thank you, Dr. Omar, for your presentation. If anyone wants to ask any question.
I don't have any questions. I just think I like that it was kept simple. There is no need to go into much details for heart failure stuff for non-specialists. I just want to add a couple of things on Omar's note regarding the furosemide during acute heart failure. So it's ideally, as he said, just to continue with the furosemide because the priority is to offload the patients. But in terms of targets of renal impairments or furosemide-related renal injury, usually an acceptable rise of 25% from the baseline of creatinine is pretty much a decent value to continue with the furosemide. If it's more than that, you just need to think whether there is an element of an acute cardiorenal affection, which is basically affection of the renal functions due to a decompensated heart. Because when someone has a fluid overload, they don't have well perfusion. And that's why just we can also consider carrying on with the furosemide. But at that point, if you feel not confident, as for non-specialists and SHOs, it's always very helpful to involve the cardiologists at that point. But in terms of creatinine targets, around 25% decrease in the creatinine values from the baseline is acceptable with furosemide. The other thing I wanted to just add on the furosemide is if you have a negative balance of 500 mils or loss of weight less than 0.5 kilograms on consecutive days, and the renal functions are affected, but the patients start to improve clinically, you can start to wean down the furosemide and just be more cautious if you want. And just for targets. The other thing, just sometimes physicians forget about when patients have an LV impairment less than 40 or less than 35%, you just need to do 2 things for them. If these patients were not seen by cardiologists, as Omar said, make sure that they are optimum groups of anti-failure medications like the A as ACE or ARBS or the interest ones. And beta blockers, and also diuretics as required, and SGLT2s. But you need to remember to schedule for these patients an outpatient echocardiogram after 3 to 6 months to make sure that the patient doesn't have severe heart failure again. Because if this is the case, they would require a referral to your non-friendly cardiologist to have a device inserted in order to prevent sudden cardiac death. But I mean, otherwise, well done for the presentation.
Yeah, I liked it. It was very simple, as you said, and it was very pragmatic, very directed to the NHS system and how they are managing heart failure patients here. I got a question from Dr. Khaled Sabah. He's asking about the preferred beta blockers in heart failure. So, I mean,
you answer. No, I'm not answering.
So, Dr. Asaf, do you want to answer this question?
Yeah, so it doesn't mean a beneficial one or a non-beneficial one. Most of the groups are been well used. Beta blockers is one of the oldest medicines in cardiology. So you have bisoprolol, nebivolol, carvedilol. All of them are well used in heart failure. One of them has treatment targets. There is no harm of starting either one of them, and you're as well. The non-friendly cardiologists can come and change them based on their experience or their recommendation. But ideally for me, for example, I really like the bisoprolol and the nebivolol. I tend to shy away from the carvedilol just for some personal experience in my practice rather than anything else.
I think I have.
Can I add a point?
B.
Just because I was like curious about different beta blockers and stuff. So bisoprolol, yes, is the most common one and the cheapest one. The selectivity of bisoprolol is 1 to 10. So it's, you know, it's you're giving beta 1 blocker, not beta 2. So if you got a patient with severe COPD or asthma, most of the doctors will be like quite cautious with giving beta blockers, but you can safely start a trial of nebivolol. This can be well tolerated because the selectivity here is 50 to 1. So it can give you the targeted results you're looking for and still keeping the patient safe from the side effects that the patient may experience if you got asthma or COPD with other medications.
Great, thank you. Actually, Dr. Sabagh is a respiratory registrar, and I think he can get an answer about that, about which one do they like in beta blockers in a patient in case of severe COPD or asthma. But he said earlier, he's saying, Dr. Khaled, are you okay to open your mic? And he's saying one of his respiratory consultants changed any heart failure patient to carvedilol. Is there any evidence behind that? I personally don't think so.
Assalamu alaikum.
I don't think there's anything.
Jazakumullah khairan. Actually, I don't know the idea of this consultant about carvedilol, but he said it improved contractility or something like that. This is his usual practice. So once in our department, once we see patient on carvedilol, we know that he's been seen by this consultant. Okay, this patient must be seen by Dr. Atteya because he is on carvedilol. But I believe carvedilol is non-selective, right? Non-selective beta blocker. So yeah, maybe for respiratory patients, it's not the preferred beta blocker. That's why I was asking, because even if the patient on bisoprolol or another beta blocker, he would change it to carvedilol.
Yeah, I see where your question coming from then.
Yeah.
Okay, Mohsen, I think you were raising your hand. Do you have a question?
No, just trying to make an action with a thumb up, but mistakenly raised the whole hand. Sorry for that.
I just googled the selectivity of carvedilol. Yes, it's 1 to 1, so it's not selective even anything.
Any other questions? Okay, I just wanted to add something. When you mentioned about ACE inhibitors and ARBs and in the acute heart failure setting, it's usually a difficult decision about it's a case-to-case variety. So not for every single patient you are going to stop ACE inhibitors or ARBs, but you just continue monitoring the patient and monitoring his response and his kidney functions, and according to that you might consider stopping. Of course, also his blood pressure, and it's actually one of the most difficult things. I mean, I came from CCU today, and we do have a patient there who's in pulmonary edema due to severe mitral regurg, and in the same time he's got AKI2. So it's very some scenarios are very difficult and will need very cautious approach with both cardiologists and nephrologists involved in the case. Yep, it was just a comment. So
Thank you.
okay, so if no one else has a question, we can call it for today. Okay, so thank you, Omar, for your presentation. A very presentation. I liked it very much, actually. And thank you guys for attending the session. I think Mohsen will post the feedback forms. Please just. Oh, thank you, Khalid.
Thank you.
Okay, thank you.
Thank you.
See you next week. Bye.
See you.
Thank you, guys.
Okay.
Thanks, Omar. Nice
Thank
one.
Thank you.